Hey, thanks, Judy. Good morning, everybody. Welcome back. Thanks for joining today. I'm going to be introducing our first session today, which is with a team from CMMI, the Center for Medicare and Medicaid Innovation. CMS, of course, is the largest payer in the land, and the work that they do to adjust their models and policies to better meet the needs of seriously ill beneficiaries has a big impact on what happens in California and creates a really useful context for the work that you all have been doing to get palliative care to Medicaid enrollees. So yesterday was all about us, all about the responses to the plan survey and the provider survey, hearing about innovations that individual programs have implemented. Today, as Judy said, is the national context. So what's going on federally, and then also what's going on with the tools that the field as a whole are using to help to elevate the quality of the palliative care that we're delivering. So we'll kick this off with a presentation from the folks at CMMI, and it's my great pleasure to introduce Dr. Jacob Quinton, who's a medical officer at CMMI, Ms. Sibel Ozcelik, who's the co-lead for Value-Based Insurance Design Model, VBID, and Dr. Rachel Fogler, who's the group director for patient care models for the Patient Care Models group. These folks will share their presentation, and then we'll go into a question and answer session where we can dive in a little deeper into what they've been doing. And also, I'd encourage you to think about your experience delivering palliative care to the Medicaid population and what we've learned over the course of the past 3 years, and anything that you want to share with the CMMI folks as they move forward with developing their own models for caring for seriously ill beneficiaries. So note your questions, put them in chat during the presentation, and then we'll all come together to have a Q&A session afterwards. So without further ado, CMMI team, take it away.
Hey everybody, thank you so much, Kathleen, and looking forward to this presentation. I wanted to say that I'm more than happy to switch the slide presentation to my deck, and we'll be working through the slides that were shared previously. But thank you so much, and looking forward to presenting to this group. As background, thank you so much, Kathleen, for the introductions. I'm a primary care internist, safety net doc. Previously, before this role, I was working at Venice Family Clinic in Los Angeles County and what used to be called the LA Homeless Clinic. Here today with Dr. Sarah Fogler, our group director, and Sibel Ozcelik from the CMMI's VBID hospice component. And so really thrilled for this opportunity, which the invitation came from Kathleen after we had been sought out her expertise to teach us the lessons learned from implementation of this palliative care benefit in Medi-Cal in the years since passage of SB 1004. So hoping for a robust discussion after the brief presentation, and certainly expecting that to be an ongoing dialogue over the next days, weeks, and hopefully months. So the team you're getting from CMMI represents two groups that have been previously implementing models serving the seriously ill population. Sarah and I are coming from PCMG, which Sarah leads, and I'm on Sarah's leadership team, and Sibel Ozcelik is from SCMG, where she co-leads the VBID Medicare Advantage model, and specifically that hospice component. To note, we were instructed to bring about 20 to 25 minutes of content to the session and to leave room for that robust discussion afterwards, which we expect to kick off right about 9:30, and we're certainly looking forward to. To note, from this national perspective, we're going to be walking our way through a portfolio of models. This is going to necessitate us to stay pretty high level in the initial description, but really excited to dive deeper into at any point later on, whether it be about a specific model, what's worked, what hasn't worked, but really, like Kathleen had said, to learn from you all who are truly leaders in the implementation of the palliative care benefits for a Medi-Cal population. And as a personal note, really excited to be saying Medi-Cal again. So let's jump in. We have three goals for our presentation. We're going to baseline or level set on the goals and history of the CMS Innovation Center. We'll articulate the strategy refresh and our vision for the next 10 years. And we'll walk through examples of previous models serving the seriously ill in very limited detail, but just for everyone's awareness. I'll scan through the introduction and strategy refresh and hand off to Sibel to walk through the 2 models from her group in SCMG, and I'll close with the 2 models in Sarah and I's group. So to start at the beginning, our statutory authority at the Innovation Center was established in the Affordable Care Act and allows us to test changes to payment policy and service delivery in Medicare, Medicaid, and the marketplace on a time-limited fashion, such that we do one of 3 things that are called out in the box at the bottom of the screen. 1, to improve quality and keep costs the same. 2, to keep quality the same and reduce cost. And then 3, to improve quality and reduce cost, the ideal scenario. Our models are typically geographically localized in a number of states, and all 4 of the example models today include or included practices from California. Then, if after that time-limited test, a model proves to the actuaries it accomplishes one of those 3 scenarios, it may be expanded to the overall Medicare program. This happened 4 times in nearly 40 model tests, and so there's been a breadth of opportunities for learning what worked and what didn't work. And certainly important for our conversation today, the largest hospice-based model, MCCM in our acronym, but the Medicare Care Choices model did demonstrate some savings, but was unable to be expanded due to the few number of hospices enrolled, and much more to come on that in a moment. This slide is a small font, scary level of detail, and useful to frame the total model portfolio as an all-inclusive portfolio. We have buckets of models in accountable care, in episode-based payment or bundles, in primary care models or advanced primary care, walking down that first column. In the middle, those models focused on dual eligible population for Medicare, Medicaid, and then some specific models focused on evidence-based practice adoption, such as cardiovascular risk reduction and using the ASCVD risk calculator. The right column is kind of a grab bag of everything else in terms of these service delivery models. And I walk through this slide only for one reason, to highlight these are the models focused on the seriously ill within the CMMI portfolio. So just to go down the left column, within our ACO portfolio, there's the comprehensive ESRD care or CEC, and the subsequent now enrolling kidney care choices model. And these are both ACOs focused on ESRD care, which recognizes the challenges of transitioning from dialysis to hospice care without a concurrent care waiver, to continue dialysis while receiving hospice or palliative care benefits. So calling out the component of the model focused on the seriously ill. For the oncology care model, an episode-based model, it is multi-payer. And it does, as many of these models do, include dual eligibility and the risk adjustment strategy, but also part of the quality strategy for OCM, or the oncology care model, is measuring the proportion of patients that had enrolled in a hospice benefit for more than 72 hours before end of life. Obviously, a very limited measurement of the robust hospice and palliative care benefits we're hoping patients to receive. But one note for the inclusion of a specific hospice measure within that quality strategy. So moving down the line, primary care first, Sibel's going to update us on this model later. There's obviously been a lot said about the serious illness component of PCF, and while that was rolled back in this fall, and we can discuss the reasons why, there does remain a category of participants focused on high-risk patient populations. These are called groups 3 and 4, and so more to come there. Moving to the right column in the Medicare Advantage value-based insurance design model, another model Sibel's going to walk us through in detail, and certainly the largest model impacting the largest number of beneficiaries who are seriously ill within our strategy. So last but not least, just below the VBID lines there is Medicare Care Choices model. And that was our first hospice model which ended last December as part of Sarah and I's group. And then this had allowed for concurrent treatment of chronic conditions while electing hospice benefits, paying either $200 or $400 per beneficiary per month for hospice care. And yes, that model did demonstrate savings, but there were some questions about the overall breadth of the model uptake, and the decision was made not to expand. So that's where we've been and where we are, in kind of a whirlwind of the overall CMMI model portfolio. But let's switch to where we're going. So in the last year, the Innovation Center has underwent an internal review of the overall portfolio of models, and reviewed the external literature, held a series of expert interviews to inform on what we learned in the first decade of the Innovation Center, and subsequently how we should pivot, or what our new strategy should be for the next decade. The 5 pillars of the strategy I'll walk through quickly, and certainly encourage you, and we should put a link to the white paper in the chat if you haven't already reviewed it. I was published this October. So the first pillar is driving accountable care. We're seeking to move more Medicare fee-for-service beneficiaries into an accountable care relationship with providers accountable for quality and cost of care, and calling out the dual-eligible population, as is said in the white paper. We're seeking to move them into accountable care relationships to manage the quality and cost of care throughout the Medicare-Medicaid spectrum. For our second pillar in health equity, we're making a special focus to include providers serving patients who are traditionally under-resourced, and including provider types like FQHCs, where I work, and RHCs that have been left out of previous models. The third pillar, important for this group, the white paper states specifically we're seeking to improve person-centered integrated care, including supporting unmet social needs and improving access to care in the community, and even calls out palliative care specifically in that section of the white paper. It's on page 22 if you're following along at home. The fourth pillar is affordability. It's of course an important strategy, and we highlight changing cost-sharing requirements and out-of-pocket cost of patients in this section, again exemplified by VBID. And then a fifth and final pillar for system transformation, we're seeking throughout the model design process, from concept to implementation, eventual expansion, to include the perspectives of all Medicare and I'll say Medi-Cal beneficiaries. So those are the 5 pillars of the new strategy that was developed and implemented before my time jumping into the Innovation Center. This is another figure from that white paper that goes through from 2021 through 2029, sort of overall the implementation of the strategy to date. And just like with that model portfolio, I've mocked up the focus on the seriously ill, and we'll walk through this fairly quickly and then jump over to Sibel to introduce our models. As we were going through, the white paper specifically calls out palliative care, noted in the top left corner. There's the listening sessions that happened actually literally just yesterday. There was a listening session on focus on participants from the safety net. In the past, we've held expert stakeholder interviews. In this fall, interfacing with AAHPM, CTAC, CAPC, and other advocacy groups focused on seriously ill beneficiaries, and that work is ongoing. The LAN Health Equity Task Force is an ongoing component of the strategy focused on equity broadly, including for seriously ill beneficiaries. And then this stakeholder engagement piece over the next 6 to 24 months, we're planning to do a lot more of this, outreaching to those that understand the work, those that have been leading in the work, and hoping to learn as much as we can. The bottom half of the slide is just commenting on the specific models so far, and we've mentioned those in primary care first, the ESRD treatment choices model, and then the new cohorts that are enrolling started January 1st of this year with the PCF second cohort in KCC. So that is what we've identified so far in terms of where we're going to be going next. Next, I will turn it over to Sibel to walk us through the first of several value-based payment models.
Thanks so much, Jake, and really excited to be here with everyone. So to start us off, I'm starting off with my favorite model, a little bit biased since this is a model that I work on, the Medicare Advantage Value-Based Insurance Design, or VBID model. And so the VBID model is actually our only model within the CMMI portfolio that is based within Part C, or Medicare Advantage. We see the VBID model as a vehicle to be able to test a lot of different innovations and flexibilities within MA. And I'll touch on a few of those innovations at a high level, and then we'll dive a little bit deeper into the hospice benefit component of the model. So at a high level, the VBID model has, again, a number of different components. I think when we're thinking about the serious illness or seriously ill population, one of the flexibilities under the model that come to mind is VBID Flex, or VBID flexibilities, specifically to allow plans to target specific subpopulations. So VBID started all the way back in 2017, and it was the first model testing what does it look like to waive uniformity flexibility and try to target specific subpopulations who could benefit the most from certain benefits or different cost-sharing arrangements. And so over the number of years, we transformed the model as the program caught up with a lot of the innovations that were happening under VBID. So right now, under the program, you can do, for example, uniformity flexibility or special supplemental benefits for the chronically ill or SSBCI. Under VBID right now, one of the unique elements of it is the ability to target populations who have a number of different chronic conditions and or low-income subsidy status or LAS status. So when we're thinking about populations with serious illness, you could imagine coming up with a benefit design where you target those with chronic illness in or complex chronic illnesses and low-income subsidy status to be able to provide them benefits to address both their medical and social needs. So for example, you could eliminate entirely all of the cost sharing for Part C services, for Part D drugs, as well as offer wraparound social needs related benefits. So for example, a healthy food card, or let's say transportation benefits, or falls prevention benefits, to really get at both the social, any of the unmet social and medical needs of populations. Now I'm going to switch gears and talk more about the hospice benefit component. So under the model, unique again to the model itself, we test the carve-in of the Medicare Part A hospice benefit, which historically has always been carved out of Medicare Advantage. So what that means is outside of the model, once an enrollee elects hospice, they remain in their plan, but original Medicare begins to kick in and cover all of their hospice related and unrelated services. And then 1 month, if someone after revocation, original Medicare will continue to cover those services. Under the model, what we're testing is what does it look like for a health plan to have full financial accountability for the entire continuum of care? So how can we reduce payment fragmentation? How can we increase accountability? And how do we think about sort of what that serious illness trajectory looks like, or that care journey? So in the model itself, next slide, we focus on 7 different elements. So as part of carving into hospice, we felt it was incredibly important to maintain the entire scope of the Medicare hospice benefits. So what that means is that plans that are participating can't unbundle what hospice is. The next piece that we thought was really important from a policy perspective is that if plans are carving in hospice, they need to have a comprehensive approach to palliative care. And so what this looks like in action is that plans are, for example, providing a lot of the same elements that you all provide in Medi-Cal, including care delivered by an interdisciplinary care team, 24/7 response rates, addressing both psychosocial and medical and mental behavioral health needs, providing assistance and caregiver support, providing respite, addressing any of the social needs. So those are some of the elements that we're seeing plans include within their comprehensive palliative care approaches. We also enable, very similar to MCCM in some ways, transitional concurrent care. What's distinct about the VBID model hospice benefit component is that transitional concurrent care can occur at the same time as when someone elects hospice, so that we can potentially reduce stigma or reduce barriers into entry for hospice. What we're seeing is that transitional concurrent care is actually helping with reducing live discharge rates, for example. The 4th element is around hospice-specific supplemental benefits. So plans are able to provide supplemental benefits that are additional to what they're already providing to members while someone's on hospice. So some of the things that we're saying are in-home respite care, for example. And then layered across all of these care delivery transformation elements is ensuring that we have a robust quality and monitoring approach while maintaining broad access to and choice to hospice, and utilizing a budget neutral payment approach. Next one. I see some questions on VBID. Jake, should I take them now or?
I honestly think that'd be great. They're so timely and so important.
Yeah, so similar to MCCM, are we seeing issues with uptake by hospices and enrollees in VBID hospice? So right now, we only have, or in 2021, we only had 53 plan benefit packages participating, or 9 Medicare Advantage organizations. So it was pretty small in terms of uptake, but we were able to get uptake across the entire nation. And it is uptake by different plans, different regions, urban, rural, continental US versus not outside of the US and Puerto Rico. And then in 2022, we've seen sort of an uptake from the 53 plan benefit packages to, I think, what's pointed out here, the 100+ plans. What that does translate to is around a figure of, 20,000 or so hospice enrollees. So it is smaller, but what we're hoping is that by year 3, we'll have potentially an increase in participation. But again, depending on some of the results that we see, there could potentially be a path to expansion if we see quality improvements as well as and/or reductions in costs. And then under the VBID model, I see another question: is it up to the plan to decide whether or not they want to offer transitional concurrent care? If so, could you share how many of MAOs are offering it? So under the model, it's not up to the plan. It's a requirement of the model to offer in-network transitional concurrent care. So what that means is that for enrollees who choose an in-network hospice provider, they're able to access transitional concurrent care through the plan. Each plan might have a different offering of transitional concurrent care. So Plan X might have a time-limited approach to transitional concurrent care where they provide TCC or best care for, let's say, 1 month of hospice selection or 2 months of hospice selection. Plan B or MAOB might have a different approach where they provide unlimited or transitional care for specific diagnosis or specific service, let's say X number of chemotherapy sessions, for example. But those are some of the initial questions. I know we're almost short on time, so I want to make sure we get to PCF or primary care first, and I'll turn it over to Jake.
Sounds great. Thanks so much, Sibel, and loving the dialogue going on in the chat. So primary care first. This was the third in a series of advanced primary care models, the first being comprehensive primary care, CPC, and then CPC Plus. And then this model was designed to be an extension of CPC Plus to building in advanced primary care capacity for practices that are ready to accept increased financial risk in exchange for flexibility and potential rewards based on performance. So they did begin implementing in January 1st, 2021. And as flagged earlier, the PCF practices are in one of two camps: either the overall HCC score or average HCC score or hierarchical condition category score for the practice is less than 1.2, with 1 being your typical Medicare beneficiary's medical complexity, or it's greater than 1.2. And so for the PCF practices where their average beneficiary is a little more high risk, they're in this what we call groups 3 and 4 high risk group. So just one more slide about PCF. A lot of text here, but highlighted in red, we actually have different requirements for participants who are in PCF but are serving a higher risk population. And so again, this is at the primary care practice level. This is focused on primary care practices that are serving higher risk beneficiaries. And so for those practices, we're requiring participants to ensure timely callback for high risk patients, collaborate with high-risk patients to develop and maintain documented personalized care plans, ensuring coordinated referral management through formal relationships, and then engaging families and caregivers. And so just flagging, while there are models that may be more specifically tuned into the seriously ill population, for those primary care practices that are enrolling the seriously ill, this is a specific carve-out or specific separate group for PCF. At least jumping into just a couple more models quickly, and then we'll open it up broadly because I know we're already at time for the Q&A. There are two ACOs that are focused on advanced kidney care, comprehensive ESRD care, or CEC, and which is in its last year, and then Kidney Care Choices, which has just started to enroll in January 1, 2022. The CEC started in 2015 and with 33 ESRD care organizations, or ESCOs, and a substantial component initially were focused on improving palliative care within their ESRD population. They ran into challenges in part because they weren't able to, as part of the model participation, waive concurrent care requirements for Medicare hospice benefit. And the quote in orange, which is actually not the easiest to read, so I'll read it out for us, highlights that. The quote says, when we asked care coordinators who were comfortable with having conversations regarding end-of-life care, about a third of them said they were comfortable. But when we asked how many of them could think of a patient in their dialysis clinic who would benefit from having this conversation, every single care coordinator raised their hand. And so that was an illustrative quote from one of the evaluations of CEC, highlighting the need for improved training for dialysis clinic staff on end-of-life care conversations. So just to note that unfortunately, because of some of these limitations, the CEC did not improve palliative care uptake within its beneficiary population, but KCC, which started just in January 1st of this year, resolved this with a conditional waiver of the Medicare hospice benefit. And so flagging this, although it is focused on a specific population for KCC, CKD 4 and above, and ESRD, just noting that of 65 participants, 9 of them are in California. And so certainly an opportunity. More broadly, the ACO population, the graphic in the bottom right corner of the slide just notes that 10% of ACOs at last time they were surveyed by an external group had put palliative care as their top priority. So we know this is important for a breadth of ACO practices, not just those focused on ESRD care. So last but not least, and then we'll formally open it up for Q&A, the Medicare Care Choices model. So more than 80 hospices were enrolled and either paid $200 or $400 per beneficiary per month, depending on if the beneficiary was enrolled for more or less than 15 days in that calendar month. And they also were able to waive the limitations of the Medicare hospice benefit, limiting concurrent care. Here, beneficiaries needed to have diagnosis of malignancy, CHF, COPD, or HIV/AIDS, and have a prognosis and a clinician, 2 or more clinicians signing that their prognosis of less than 6 months. This model ended in December and had run for the previous 6 years. At its peak, had 140 hospices enrolled. And despite, unfortunately, because with its very promising results for reducing spend and improving quality, there were more than 50% of the beneficiaries were enrolled in just 8 or so of the hospices. And so because of concerns around generalizability, to my personal interpretation, the model wasn't selected for expansion. So while that model has sunset, there are certainly multiple models currently in existence and to help support the serious ill beneficiary population. Really excited to have the opportunity to learn from you all with regard to your expertise, and particularly in the implementation of the Medi-Cal palliative care benefit after SB 1004, and thrilled for the opportunity to I think we have just about 15 minutes for a Q&A. So thanks for following with us on this whirlwind, and I'm really looking forward to the conversation. I will pull slides down, Kath.
Great. Hey, thank you. Thank you for that run through of decades of work in 20 minutes. No small feat. Really appreciate it. And folks, and thank you also for addressing the questions about VBID as they came up. Folks, feel free to add questions to the chat or comments or observations, things that you want to share with our presenters. I wanted to start off with I have a couple questions. One is about MCCM, and that was sort of a non-disease specific model that was aimed at the seriously ill population, obviously very closely defined. You had to be hospice certified, a specific set of diseases, but that didn't get moved forward with, I think for understandable reasons because of uptake. I'm curious about the CMMI current position on creating something else that is aimed at the seriously ill population, not linked to a specific disease, but something kind of like SB 1004, where there's a community-based benefit, a benefit that would cover home-based palliative care. Is anything in the works there, or things that you've thought about that would make that attractive, or too many barriers? What's the perspective now?
Well, you've heard quite a bit from me on these topics. Sarah, I wasn't sure if you wanted to jump in with this one, or I'm more than happy to.
Yeah, happy to. So hi, everyone. Thanks for the opportunity to participate and learn and respond to some comments. And I think I would say with the new strategic refresh, we've pivoted a bit to wanting to have more integrated models of care tests. And so with that comes a charge for all of the model teams that are in design and development mode to think thoughtfully around how we can promote to some degree in a similar fashion as we have in the past, where we embed some of these key design features like the delivery of palliative care services within a number of models and don't have a discrete model outside of the transformation work we have operating in other model designs, but instead offer this kind of embedded integrated approach. And that can take many different forms. And we've been talking about it more seriously over the last couple of months around, is it a combination of features where we have benefit enhancement waivers, like some exist right now for expanded home healthcare delivery through certain participation in ACO constructs, for example. We've thought about that for palliative care. We've thought about like whether or not we should have tracks within existing models that focus on palliative care and complex patients. We've thought about discrete models. We've thought about learning system approaches. But I think generally where we are is we want to have broader impact, and just given our experience in some of our discrete models where we focused on these populations, they've either been operationally really hard for us to get at, or they've resulted in numbers where the findings are great, but we're not able to generalize because enrollment is so low, both on the hospice participation side and also like the beneficiaries we're able to enroll. So I would say right now we're in design mode, again, thinking through what are the strategies we can employ that have broader reach and the opportunity for findings to be generalized. And, there is definitely an interest in capitalizing on these population-based models that are kind of more all-encompassing, I would say, than some discrete models we've targeted in the past. So that's where we're headed. And specifically around community-based palliative care, I don't think we're in a place, at least in the model arena, in the Innovation Center, where we are going to design a model solely focused on the delivery of community-based palliative care. But I will tell you that that is a feature of a lot of the design conversations we're having right now in some of the accountable care, larger constructs we're discussing around primary care, around accountable care organizations, state-based models, et cetera. So a bit of a long-winded answer, but I hope it was helpful.
It was, and the note on one of your slides about 10% of ACOs putting palliative care as their top priority, to me, I'm like, oh, wow, that's very few. And so hopefully along the way, as people will recognize the ability to fold coverage for services like this into those broader payment constructs. We have a ton of questions. So let me throw this one out. Are elements, and this is from Barb Hansen, are elements of MCCM going to be utilized in the design of a community-based palliative care pilot project per federal bill SB 2565?
Yeah, I mean,
Thanks so much.
Yeah, go ahead, Jake. Were you gonna?
Oh, two things. One, just to say, Kathleen, that is the 10% that palliative care is their top strategy. I think there's a much larger number of ACOs that are including improving care, palliative care as an overall, as one of their top strategies. And I think that's the number, just the percent of ACOs that have the number one spot. So that's at least so that's encouraging. I think the other thing to say regarding this specific legislation, so if I Googled the externally facing bill text and the legislation is calling for us to implement a new nationwide demonstration for palliative care, community-based palliative care. And this is just reading from the external information that's available for the text. So that's at least what the bill is calling for. I think that's as far as I know, but Sarah, you may have more to say.
Yeah, I was just going to say, there's a lot of bills that are at least explicitly or directly or indirectly touching the concept of community-based palliative care, and we're reviewing all of those. And on some of them, we're being specifically asked for technical assistance for our Office of Legislation. So we're actively reviewing and internalizing, for lack of a better word, the details of that legislation, and it's certainly informing our thinking about a broader community-based palliative design. But I think the current thinking again is just steering more towards how can we integrate that in these population-based models so that our reach is broader and not narrowly, anchored within these smaller, discrete models where we run into those operational challenges. The other thing I just wanted to flag too is I think we are in a position right now where we are diagnosis agnostic thinking about this, and are certainly we've put a lot of energy into thinking how we can do a better job identifying patients that would be benefiting from this package of services upstream, like way beyond the 15-day mark. Like we're talking like the 12-month out mark in terms of like how we can get the ball rolling on assessment and referral earlier so that people are able to capitalize on those services for a longer time period and not within the last month of life. So I just wanted to offer that additional color in terms of our design.
Yeah, useful to hear about of population focus and using existing levers and data and incentives and so on. A very specific question about VBID. Does a VBID plan need to pay the Medicare rates to a hospice, or can they negotiate their own rates with the hospice? Is there a reimbursement floor if the plan can negotiate their own rates?
Yeah, no, Jill, that's a great question. So in terms of, and I see some of them like the payment rate book. So by way of background, the payment rate book that's linked or on the Viva Models website is the payment, the monthly capitated payment that CMS pays to the plans. We have a contracted arrangement with the plans that are participating in VBID hospice. Then the plans can go ahead and negotiate and contract with any hospice that they want. We do have specific requirements around how they contract. For example, we require that contracting with a hospice provider. The hospice provider has to be high quality. That the contracting basis has to be based off quality, not cost alone. But in terms of the actual rate between the plan and the hospice, we don't, as CMS, interfere in those contracting arrangements and the payment rates that are being passed to the hospice. But of course, we have a protection in the model itself. So a hospice can choose not to contract with the plan, still take care of plan hospice enrollees, and be reimbursed at 100% of original Medicare rates. So for out-of-network hospices, you get your 100% original Medicare rate. That's continuing into your plan year or calendar year 2023. If you do choose to contract with a plan, you get to sit at that table. You get to negotiate your rates. It's not just the plan that's negotiating the rates, right? It's also you as a hospice provider, and it really should be that partnership. And that's what we've been encouraging since day one when we originally announced the model. So I hope that's helpful.
Yeah, and I think that's similar to the stance that the Department of Healthcare Services took in California for palliative care. One final question before we get to the break. Would CMMI be willing to work with Medicaid managed care plans to implement a multi-payer model for accountable care, or would the focus be limited to Medicaid fee-for-service patients?
So I can start. So at a high level, as outlined in the CMS Innovation Center strategy refresh, multi-payer partnership is incredibly important to CMS. Not just a partnership, but also potentially alignment to reduce burden on providers. So for example, what you'll see, let's say in the primary care first or PCF model that Jake went through, we allow for multi-payer partnership and alignment with lots of payers from commercial to Medicaid managed care as well.
Yeah, and I would just note before everybody goes on break, I agree with everything Sibel said. I mean, to some degree, certainly multi-payer alignment is central to our CMMI strategy refresh, and we're definitely interested in continuing efforts in the multi-payer alignment space. To some degree, I think we've talked more about alignment in the commercial and Medicare space and are later to the table on the Medicaid space, but I'm happy to report that activity has really kicked up. And so I think we're going to see more coming out of the multi-payer alignment work, and many things are on the table today that maybe weren't some time ago.
I'm glad you're coming to the table. We're going to your table. There's a table now. We'll all get together at it. Hey, I really want to thank you guys for taking the time to prepare that summary of your current portfolio, to come and answer some questions from our group. Really important for us to know what's going on in the federal level and how we can get to that space where no matter what insurance coverage a seriously ill individual has, they have access to the supports that they need to live the best life possible. And I think conversations like this and the work that's facing us in the coming months and years will help to get us there. So thank you again very, very much. Truly appreciate it.